Hi there, my name is Dr. DJ Heusler. I'm a veterinary ophthalmologist in Cincinnati, Ohio. Thank you so much for having me. And today we're going to present corneal emergencies in dogs. So what are we going to be talking about today? Today we're going to be talking a little bit about some anatomy of the cornea, traumatic superficial ulcers, ulcers secondary to eyelid disease, ulcers secondary to foreign material, anterior stromal ulcers, deep stromal ulcers, desmetaseals, melting corneal ulcers, corneal ruptures, surgical therapies, and corneal lacerations. So the cornea is composed of about 4 different layers. The top layer is the epithelium. The middle layer is the stroma. The second to last layer is Descemet's membrane. And the last layer is the endothelium. And the cornea is about 0.5 to 0.6 millimeters thick. The cornea supports the internal contents of the eye. It refracts light, it transmits light, and the aqueous humor and tears supply its nourishment. It's avascular, and it's typically less than 1 millimeter thick. The anterior epithelium is approximately 25 to 40 micrometers thick. It's composed of 2 to 3 layers of non-keratinized, stratified squamous epithelium. There's a single layer of basal cells, and there's about 2 to 3 layers of wing cells. The stroma consists of approximately 90% of the thickness of the cornea. The stroma is composed of keratocytes, which possess crystallins, which are believed to facilitate transparency, and they can transform into myofibroblasts during deep corneal injury. And this forms scar tissue and what causes the cornea to lose its transparency. The stroma has collagen fibrils, which are broad belts called lamellae that run parallel to the corneal surface. Within the stroma are nerves, as well as glycosaminoglycans, which are composed of keratin sulfate, chondroitin sulfate, and dermatin sulfate. Innervation of the cornea is provided by branches of the trigeminal nerve, and these branches enter into the midstromal region circumferentially at the limbus. They course radially to the central cornea in the anterior stroma, and the free nerve endings extend to the epithelium. Brachycephalics have less nerve fiber density than mesocephalics, and dolichocephalics are more sensitive and more painful. And this could be thought as to why there is far less ulcer development in dolichocephalics as compared to brachycephalics. If they can feel pain more commonly, then this provides a barrier to less ulcer development. And as well, diabetics have reduced corneal sensitivity. So outside of diabetic cataracts, diabetes causes decreased corneal sensation, increased risk of corneal ulcers, increased risk of infiltrated corneal ulcers, and increased risk of fungal keratitis, as well as increased risk of keratoconjunctivitis sicca or dry eye. Descemet's membrane is the basement membrane of the posterior endothelium, and Descemet's membrane thickens as the animal ages. The endothelium is composed of a single layer of flattened cells, and it's thought to be possibly regenerative in younger animals. It has a density of approximately 3,600 cells per square millimeter in dogs less than 1 year old. And as the animal ages, they will lose greater than 50% of these cells. And then other cells become pleomorphic at this time. They become wider in order to provide the function of the endothelium. In older dogs, there are typically less than 2,100 cells per square millimeter. The endothelium is composed of sodium and potassium ATPase pumps, which actively pump fluid out of the cornea to keep the cornea relatively dehydrated. So the cornea is approximately about 75 to 85% water. The endothelium regulates hydration of the corneal stromal collagen, which provides mechanical strength to the cornea. So as this cornea pumps fluid out of the cornea, it keeps the cornea clear and free of corneal edema. As the sodium potassium ATPase pumps no longer provide their function as the animal ages, that is when these animals develop corneal degeneration or corneal edema. The peripheral cornea is thicker than the central cornea, and this decreases in corneal thickness until approximately 6 weeks of age. Then it increases until the dog is approximately 30 weeks of age. Determining the etiology of the ulcer is incredibly important. Is it due to trauma, foreign body? Is it due to eyelid abnormality, tear film disorders? Is the ulcer indolent? Is it infected? Is it due to exposure? So let's go over some traumatic superficial ulcers, which we can see in an emergent basis in everyone's practice. Traumatic superficial ulcers are typically uncomplicated. They usually heal within 1 week if given the correct medications, and they typically do not penetrate further than the epithelium. And many times, these owners will frequently see the injury. So this is Rascal. Rascal is a 3-year-old male boxer, and the owner's 5-year-old son shot Rascal with an airsoft gun on Christmas morning. And here on this picture, you can see right where the pellet hit Rascal, right in the center of the eye, and caused a superficial, non-complicated ulcer, meaning that there are no signs of infection within this ulcer. So how we treated Rascal is we treated Rascal with topical triple antibiotic 4 times a day for 1 week, and we gave him 1 drop of atropine at the time of the examination in order to provide mydriasis and pain control for Rascal's eye. Here's another case of Max. Max was a 3-year-old male castrated terrier, and when the owner came home from work, the owner threw a set of keys across the room to land on the couch, and Max jumped up and the keys hit him in the eye. As you can see in this picture right here, this is where the key struck Max right in the eye and created a bit of a dent there and pushed that stroma and epithelium laterally. We treated Max with ofloxacin 4 times daily for 1 week. Used ofloxacin on this case because it's a little bit stronger. It's a broad spectrum fluoroquinolone. This ulcer has a little bit more depth to it, so I wanted to use something a little bit stronger so that it didn't get infected. Also gave him a drop of atropine at the time of the examination. And after about 1 week, this is what remained. There's a little flash artifact right here, but right here is the triangular scar, which you can see outlines this area quite nicely. And this scar should fade over about 3 to 4 months. Corneal scars in dogs fade more easily the younger that the patient is. The older the patient is, I usually will tell the owner that the scar may not fade if they're 8 or 9 or 10 years old or older. But if they're 5 years old or less, then the scar will fade over time and the owner won't even see it as the patient ages. So sometimes ulcers secondary to eyelid disease also present as emergencies based on infection and degree of complication. So many times these are typically superficial. However, they can be complicated if there's bacterial involvement. The location of the ulcer is extremely important, and correcting the underlying issue is paramount. So in this particular case, this simple 1 distichia here at the top of the eyelid created a melting ulcer, which provided an emergency for this patient. So you can see here with this bulldog, this 1 pointed distichia poked right at the patient's eye and created the melting ulcer. And we have nice, broad corneal blood vessels throughout the cornea, trying to reach that ulcer there. The ideal treatment in this case would be cryoepilation. However, this owner did not want to pursue surgery due to financial concerns. So how should this be treated? Well, we used ofloxacin 4 times a day, terramycin 4 times a day, optics care 4 times a day in order to lubricate the cornea, and then doxycycline twice a day to reduce the corneal melting. And then we rechecked in about 5 to 7 days. And here we can see the melting stopped. The blood vessels reached the bed of the ulcer to help heal. And the distichia still remains. And we epilated that at this visit. And then we kept this patient on optics care long-term to try to prevent any ulceration from further distichia. Ectopic cilia is another ulcer that can present, which appear to be an emergency to the client. These are typically young patients. These patients are exquisitely painful and are typically shutting their eyelid quite aggressively. These ulcers are almost always at the 12 o'clock position. So here we can see this is where our ulcer is here, which would line up with our ectopic cilia, which is right there. We have a superficial ulcer right here, which lines up with an ectopic cilia right there. And we have a superficial ulcer right here, which lines up with our ectopic cilia, which is right there. Bulldogs, Shih Tzus, and Pugs seem to be at a higher risk for these. That's the most that I see in my practice for these ulcers. And what these will typically present as a dog less than 2 years of age, holding its eyelid completely closed and very painful. And the key is to identify an ulcer at the 12 o'clock position, and then flip that eyelid up and look under magnification and find the ectopic cilia. Surgical excision is necessary with cryoepilation, and magnification is necessary. So we can see our ulcer right here in this picture. The ectopic cilia is located right here. And in this patient here, this is where the eyelid, where the hair and hair follicle was excised, and then the eyelid was cryoablated. So you can see the little white mark there where the cryoablation occurred. And then we just have a small scar there on the cornea, which will fade over the next 3 to 4 months. We want to treat the corneal ulceration with triple antibiotic solution 4 times a day, oral carprofen for 7 to 14 days. And then we want to recheck this patient in about 2 weeks. And all should be healed at that point. And then over time, we just want to warn the clients to watch for any sort of recurrence of clinical signs, because ectopic cilia can form in a different location. So these ulcers are also secondary to eyelid disease. And with some of these, we can see that they do present as emergent cases. For instance, this patient right here has a melting corneal ulcer, and this is caused by a medial entropion, which is located right here. We see this quite commonly in pugs. You can see the corneal pigmentation, as well as the corneal vascularization, followed by the corneal edema all the way out to here. And then we have our melting corneal ulcer right here, and that has about a 20 to 30% depth of ulceration. And that starts to become an emergency here that needs to be addressed. We have other cases which maybe are not as emergent, but we have significant eyelid disease here with eyelid notching right here and right here, which has been done over probably the last 6 to 8 months. We have macroblepharon, which is too much eyelid, which rolls all the way out to here. And then we have an upper eyelid entropion and lower eyelid entropion. And this is causing this corneal ulceration right here, which we see with corneal vascularization. And then we have our corneal edema and corneal ulceration right here. This type of ulcer here, we see these quite commonly in golden retrievers as they get older. As golden retrievers get older, this eyelid starts to have some laxity to it. It starts to fold inward, and we see these eyelid hairs start to tilt inward and start to rub on the cornea. Now, this is a superficial ulcer that's been going on for quite some time. This is granulation tissue here, corneal edema. This patient's losing vision. And so surgical therapy to take a piece of a modified Holt Celsus up here and roll that upward would help this patient out. We can also do a debridement with a Q-tip here of the corneal surface, and that'll help stimulate some healing. This is a lower eyelid entropion. This is not yet an emergency situation, but I wouldn't say it's an emergency situation, but it should be managed fairly quickly. And that is that we have a lower eyelid entropion here. And this is causing a lateral lower superficial ulcer right here. This particular patient has distichia throughout its lower eyelid. It has an upper eyelid entropion, a lower eyelid entropion, and eyelid notching. And here in the center, we have a desmetocele, which is all the way down here, and then 360 degrees of corneal vascularization that is coming in to try to help heal that desmetocele. With this particular case, this would be considered to be an emergency. We should provide some form of corneal grafting with this cornea, either Acell or Biosis grafting, either conjunctival pedicle graft or a corneo-conjunctival transposition, as well as cryoablation of the eyelid margin, repairing the lower entropion, repairing the upper entropion, repairing the notch by removing that notch and providing a blepharoplasty. All of these consist of repairing the eyelid and providing antibiotics, either triple antibiotic or ofloxacin 4 times a day. So triple antibiotic may be useful in a case like this with a superficial ulcer, same as this one right here. But in the deeper ulcers, we should be using ofloxacin here, ofloxacin here, and ofloxacin here, as these show bacterial involvement. See ulcers secondary to foreign material quite often. So suture material from previous corrections are a common cause. This was Gigi. Gigi is an 8-year-old female mixed breed dog, had a previous eyelid tumor that was removed, and the eyelid was sutured with 3/0 PDS. This case had suture material that went full thickness through the eyelid and rubbed on the cornea. So 3/0 PDS is far too thick for this, and you can see that our knot quality is not very good. And this suture was going full thickness through the eyelid. And here we see that the eyelid margin was not managed correctly with a suture throughout here. In this particular case, especially with eyelid tumors, we should be using something much smaller and non-absorbable like 6/0 Proline. So I removed the suture material from the eyelid and then debrided the ulcer with a Q-tip, debrided the corneal surface with a Q-tip, provided triple antibiotic 4 times daily, terramycin 4 times daily, and then atropine at the time of the examination. And then this healed within 2 weeks. So another ulcer secondary to foreign material. This patient was incredibly painful and was seen on emergency. This was Fritz. Fritz was an 8-month-old Great Dane and 8 weeks post-op repair of a cherry eye. So he's 8 weeks post-op after cherry eye repair. The referring veterinarian tried multiple antibiotics that did not help to heal the ulcer over the past 8 weeks. One thing we need to think about as practitioners is if you're trying multiple antibiotics and you can't get it to heal, you're probably not on the right path and not identifying the correct problem. So in this particular case, the eye is telling you exactly where to look. First of all, we have a history of a cherry eye repair, and we have to think that if this ulcer went all the way back to after the cherry eye repair, then the cherry eye repair probably has something to do with the ulcer. So in this particular case, there is corneal vascularization coming up from just underneath the third eyelid, some corneal vascularization here. And then we have a superficial ulcer that takes up about 70% of the corneal surface, where this third eyelid happens to be rubbing across the cornea like this the entire time. So the eyelid is telling you exactly where to look. 3/0 PDS was removed from the third eyelid. We shouldn't be using 3/0 PDS. That's far too thick, far too large of a suture for cherry eye repairs or prolapse gland of the nictitans. We should be using something much smaller, such as 6/0 Vicryl, in order to repair these. Triple antibiotic was used 4 times daily, and the ulcer healed in about 2 weeks. This was another case that presented on emergency for exquisite pain of the cornea. This is Sam. He's a 2-year-old male neutered mixed breed dog. And there was an unknown history as he was just rescued by the owner. His veterinarian put him on multiple antibiotics, which did not improve the patient. So as I was looking at Sam, this is how I initially saw him, and I noticed, well, he had a little notch here in the third eyelid where it looked like something occurred. And so I thought, well, this third eyelid was in some way damaged. As Sam moved his eye, and of course we can see the ulcer here with loose epithelium and active vessels. This looks like an indolent ulcer, but Sam is too young to be to have an indolent ulcer. So as Sam moved, this piece of black material caught my eye. So I retropulsed the eye, like here, and we see this large gland that was tucked down in there, and this large suture of non-absorbable suture that was placed in the third eyelid to repair this cherry eye. And again, this suture is far too large to be using for this type of repair. So I removed the suture, debrided the corneal surface with a Q-tip, provided triple antibiotic solution 4 times daily for a week, and gave him some atropine, and he was healed in a week. Switch here and talk about anterior stromal ulcers. Anterior stromal ulcers, they penetrate through the corneal epithelium and into the anterior stroma. They typically have bacterial involvement, and most of these are medically managed. So we see this case again that we saw earlier, which showed up in our traumatic ulcers. And this one had a little bit of anterior stroma involvement, which we went over prior as to why we provided ofloxacin. We see this case here. This ulcer has a little bit more of anterior involvement, about 15 to 20% depth. We see conjunctival hyperemia around the edges, as well as corneal vascularization that is approaching the ulcer to help heal. So many lag ophthalmic dogs develop these ulcers in the center of their cornea. These are primarily due to an incomplete palpebral response, and it is important to monitor them closely. And so what I tell owners with lag ophthalmic dogs is that as their eyelids blink, they don't get a complete blink every single time. And some of these owners will even discuss about how their dogs will sleep and they'll notice that their eyelids are slightly open. And if their eyelids close, they'll be open right here in the middle, and that's exactly where these ulcers happen. So if you have a lag ophthalmic dog that develops an ulcer right in the center of the cornea, and the client is asking, why does this occur to their dog, or how did this occur? It occurred due to an incomplete palpebral response. Then that center part of the cornea dries out and develops a corneal ulcer, and then doesn't heal appropriately. So when we have anterior stromal ulcers, we give them something that's a little bit more effective, a little bit more broad spectrum with ofloxacin 4 times daily. And we provide either genteel gel or optics care, which may prevent ulceration and help them more quickly, help them heal more quickly. And we send them home with an e-collar, and we recheck these in about 5 to 7 days. One thing to remember with these is to never grid these ulcers. It's important to distinguish what is an anterior stromal ulcer and what may be an indolent ulcer. So if you're not sure if it's an indolent ulcer or not, don't do a grid keratotomy to these patients. And so one thing that I always tell my clients with these dogs that are lag ophthalmic dogs is, if you put them on some optics care or a lubricant 3 times daily all the time, they will not develop these ulcers, not very commonly, and they typically don't get into any sort of emergency surgical therapy throughout their life simply by lubricating the eye effectively. Deep stromal ulcers, this is where the ulcer penetrates through the corneal epithelium and into the deep corneal stroma. Most of these have bacterial involvement, or they have calcific degeneration in our older patients. In deep stromal ulcers, medical management becomes more risky, and many of these are managed surgically through corneal grafting. So when we look at these deep ulcers, this is a melting corneal ulcer here. We see that this gets closer to 70 to 80% depth. There's conjunctival hyperemia and conjunctival edema, corneal edema. We see the melting portion of the cornea right here. And we see corneal infiltrate, corneal edema, and then more of a deeper corneal ulcer there. In this patient here, we've got an ulcer of about 90% depth. We have corneal vascularization that's approaching the bed of the cornea, the corneal ulcer, and corneal edema throughout the cornea as well. So deep stromal ulcers is where there is greater than 50% of stromal loss throughout the cornea. So 50% or more. And when we get to this point, it's time to start thinking about surgery. We also think of deep stromal ulcers, there is bacterial involvement, which allowed it to get this deep, or there's corneal melting. Options at this time include aggressive medical management or referral surgery. If we were to medically manage these patients, what I typically do is I use ofloxacin 4 times a day. Then we add triple antibiotic solution or cefazolin also 4 times a day, terramycin or oxytetracycline 4 times a day, and this helps to stop the melting process. We use doxycycline twice a day, usually about 5 milligrams per kilogram twice a day, also to help stop the melting. An e-collar, and then we recheck again in about 5 to 7 days. What I typically advise clients is that we do not think that these will be healed in about 5 to 7 days. We just want to make sure that we're stabilizing them so that they're not getting deeper or they're not melting further. So here with this eye, we've got a deeper corneal ulcer, probably about 80 to 90% depth here. Corneal vascularization, this arborization of the corneal vessels here and here, and then corneal edema throughout the cornea there at the leading edge of the blood vessels. In this patient, about 80% depth corneal ulcer. We have just the beginnings of corneal vascularization starting perilimbally, and then broad corneal edema throughout the cornea as well. And this one, even though it's located centrally, may have also been done by a little bit of this medial entropion that we see throughout here. So with deep stromal ulcers, surgical therapies that we can utilize include conjunctival pedicle grafting, which provides a stronger corneal structure, has a better watertight seal. There's minimal inflammation as we're using the patient's own tissue, but it can provide a blind spot. And so this here is a conjunctival pedicle graft. It's a minimal blind spot, minimal inflammation. It's nice and healthy. We could always go back and trim this portion as well. We'll talk about this in the future here. This is an Acell or Biosis graft, which is an artificial graft that we suture to the cornea. So Acell grafting typically has a weaker corneal structure. This is a very thin graft throughout here. It's highly inflammatory as it's not the patient's own tissue, and we're using absorbable sutures here, which is vicryl, ADOT vicryl throughout the cornea. However, this provides a very minimal corneal scar. When this heals appropriately, there will only be a faint corneal scar, much more faint than a conjunctival pedicle graft. A desmetacele is where the ulcer penetrates through the epithelium and through the stroma to reach Descemet's membrane. Most of these have bacterial involvement or calcific degeneration. There is an extreme risk of corneal rupture, and surgical grafting is required. And so if we look at this picture here, this is an elderly patient that had significant corneal calcium within the cornea that the patient sloughed. And so as the patient sloughed that calcium, there's left with a desmetacele all the way down to the final layer before rupture. There's active and inactive blood vessels and corneal pigment throughout the cornea. You can still see some of the corneal calcium that remains around the edge, and then corneal edema. In this patient, this was a patient with severe dry eye. So this patient had tear production of less than 2 millimeters per minute. And this left a very large desmetacele. Here we see in the anterior chamber as well as a hypopyon, which is reflex uveitis due to the desmetacele. Perilimbal blood vessels that are just now starting, corneal edema, so we get a hazy view of the inside of the eye, and then conjunctival hyperemia around the outside, and then your typical mucoid discharge secondary to dry eye. With desmetaceles, medical management frequently fails and results in a corneal rupture. So surgery is required for a successful outcome of these cases. The most common ones are conjunctival pedicle grafting, Acell or Biosis grafting, as well as corneal conjunctival transpositions or CCTs. Melting corneal ulcers is a progressive stromal dissolution or keratomalacia. These are the most complicated and dangerous ulcers that we see, and these absolutely show up as corneal emergencies. Normally, proteases and collagenases are produced by corneal epithelial cells, fibroblasts, polymorphonuclear leukocytes, and microorganisms. These remove devitalized cells and debris from the cornea. And so this is severe melting corneal ulcers. This has a corneal rupture right here. There was dissolution of the entire cornea out to here, active blood vessels, conjunctival hyperemia, mucoid discharge. In this particular case, this melting corneal ulcer, this case was caused by a dog that got in the way of a power washer. The owner was power washing their driveway, and the dog got in the way and was hit by the power washer right in the eye, which created this melting ulcer. And so we see diffuse corneal edema, corneal infiltrate right here, a melting corneal ulcer, which is approaching 80% depth, active corneal vessels, conjunctival hyperemia. In some ulcers, these proteases and collagenases contribute to enzymatic activity of the cornea, which is also known as melting. These ulcers typically start with a bacterial component, and treatment is aimed at stopping the enzymatic breakdown and eliminating the bacterial infiltrate. Corneal rupture is absolutely imminent if the proteolytic activity is not stopped. Anti-proteolytic agents that we can use, the most common ones that I use are tetracyclines, which is either terramycin or doxycycline. N-acetylcysteine is used commonly, so is EDTA, and then, of course, the dog's own serum. And so here we see two melting ulcers. So here's our melting ulcer throughout here. It's most dense right in this area, but then up through here as well. There's conjunctival hyperemia and corneal edema, corneal vascularization. In this melting ulcer, we see conjunctival hyperemia, corneal vascularization, diffuse corneal edema, conjunctival edema, and then all of this is the patient's own cornea, which is melting. So this is the patient's cornea, which is attaching to the eyelid, and that is just completely melting off of the corneal surface. So we'll talk about a interesting case that I had, which is Emily. Emily is a 10-year-old Papillon, which presented for acute onset of squinting and ocular discharge. The Schirmer tear test was 15 millimeters per minute in both eyes. What we noticed on presentation was there was a large geographic corneal ulcer with keratomalacia and corneal infiltrate. So all of this is melting all the way out to here. We see conjunctival hyperemia, active perilimbal blood vessels, corneal edema, and we start to see some hypopyon within the anterior chamber. With a graft this big, we were unable to graft the cornea without blinding the dog. So we could have grafted the dog with a conjunctival hood graft. However, this would have completely blinded the dog. However, there was also minimal normal cornea to suture a graft. So it would have been a fairly difficult graft to properly adhere to the surface. So the owners elected for medical management of this ulcer. So we treated this ulcer quite aggressively with ofloxacin every 4 hours, tobramycin every 4 hours, triple antibiotic every 4 hours, terramycin every 4 hours. We treated tacrolimus every 12 hours as I was concerned that the patient was dry. With an ulcer of this significance and only having a tear production of 15, that worried me that there was some reflex tearing from the ulcer and the tear production was actually much lower. So we used tacrolimus every 12 hours. Carprofen every 12 hours for anti-inflammatory effects and pain control, and doxycycline 5 milligrams per kilogram every 12 hours. And then we had them had her wear an e-collar as well. We rechecked in 2 days, and this is what the patient looked like in 2 days. It remained very malacic at its examination. And I warned the owners that this doesn't look good and it may rupture. However, the melting was consolidating ventrally. So here we see that the melting is starting to consolidate ventrally in the cornea. There's a little bit of hypopyon. Around here, the cornea was starting to get a little bit more firm. The blood vessels are progressing. And then there's some conjunctival hyperemia. We rechecked in about 3 days. So the peripheral cornea remains firm, and there's more normal cornea that is forming. Conjunctival hyperemia. This corneal vascularization is progressing. It's not as malacic ventrally, and it has not ruptured yet. I discussed with the owners, well, she's holding her own at this point. The owners elected to proceed with medical management. They were happy with how things were going so far. The owners were able to stay at home, which helped out because the owners were on medical leave themselves. And so they were able to medicate Emily throughout the day. If they weren't able to medicate Emily throughout the day, then I would have recommended that this animal be hospitalized. So we rechecked in a few days, and this was dramatically improved. The cornea was dramatically improved. There was adequate corneal vascularization now that was approaching up to the ulcer bed. The cornea was consolidating throughout here. This patient continues to be visual and would be a good surgical candidate at this point. I could now put a graft here with an Acell graft if they wanted to, but the owners were happy with the progress so far and didn't want to pursue surgery at this time since we've made such dramatic improvement over the last week or two. So we rechecked in about 2 weeks. The corneal ulcer had healed. There was a small amount of remaining inactive corneal vascularization throughout here. You can see that there's a large corneal scar that's forming, some corneal pigmentation. There's less conjunctival hyperemia. There's a little bit of granulation tissue here in the center, corneal pigmentation nasally. This patient was very comfortable, and she continued to see, but it was limited due to the corneal scar. Rechecked in about 4 months. There was a large geographic corneal scar that we can see here, but not as dense as the previous picture. There's faint corneal pigmentation from the scarring throughout the cornea. This patient was visual, she was comfortable, and the owners were very happy at this time. So this is a corneal rupture. We'll talk about corneal ruptures now. This is a full thickness corneal penetration. And these frequently involve iris prolapse, fibrin plugs, hyphema, and aqueous leakage. Sometimes it's hard to tell if you look at this photo compared to the previous photo with the melting ulcer. It can be difficult to tell the difference between a melting corneal ulcer and a full thickness corneal rupture. One clue that I could give you to help with that is that if there is pigment flakes within that area, that's a corneal rupture. And the reason is that these are pieces of the iris, pieces of the uvea that have gotten caught within the rupture. And so we also see diffuse corneal edema, conjunctival hyperemia, can barely see inside the anterior chamber, and then we've got corneal vascularization that is approaching the ulcer. If you're also unsure as to whether or not there's a full thickness corneal ulcer, we can also look here. And this is a Seidel test. A Seidel test involves placing some corneal stain, fluorescein stain, on the ulcer. And what we can see here is that this aqueous is now moving the stain, and you can see it flowing outside of the cornea. So if you're unsure as to whether or not it's ruptured, then perform a Seidel test. And this, there you go. You can see there that aqueous came through that hole there and moved the fluorescein there again. So the fluorescein doesn't just stay put in the ulcer. You can see it flowing away from the cornea. So some important considerations to make is, does the patient have a menace response? Does the patient have a dazzle response? Does the patient have a consensual pupillary light response? If the patient does not have a consensual pupillary light response or a dazzle response, vision is not likely salvageable through grafting techniques. And at that point, enucleation would be warranted. Surgical options, if they do have a menace response or a dazzle response and a pupillary light reflex, a consensual pupillary light reflex, would be a corneal conjunctival transposition, Acell grafting, conjunctival pedicle grafting, and corneal transplantation, or an enucleation if the patient could not see and did not have a dazzle response. So these are all examples of corneal ruptures, and these can be kind of confusing. You have to look at them sometimes because some of them look like melting ulcers, some of them look like deep ulcers. They don't always are a typical appearance of a corneal rupture. So here we went over this patient at the beginning, which is a corneal rupture, and here you can see the uveal pigment there within the rupture. And if we look at this photo here, we can see that here as well. There's little uveal pigment pieces within the rupture here. And so this isn't a melting ulcer. This would be a fibrin plug, uveal pieces. There's diffuse corneal edema, active 360-degree corneal vascularization, and conjunctival hyperemia. This picture here, diffuse corneal edema. There's a corneal rupture, a very small one. You can see a little bit of the fibrin coming out here. Conjunctival hyperemia, 360-degree corneal vascularization, subsequent ulceration outside of the rupture as well. Here we have a corneal rupture right here. Active corneal vessels, which are approaching the ulcer bed, meiosis of the pupil, and conjunctival hyperemia. This is a corneal rupture right here, and we can see how it's bulging forward like that, and that's a rupture. If you look really closely, there's some uveal pigment pieces within the rupture. There's corneal edema, and corneal vascularization, and significant conjunctival hyperemia. This corneal rupture here, this was caused by an anterior lens luxation. So as this anterior lens luxation has come forward and continued to strike the back of the cornea or the endothelium, it caused corneal decompensation. We see a corneal rupture centrally, active corneal vascularization, 360-degree active corneal vascularization as well. So for desmetocele and corneal rupture surgical therapies, conjunctival pedicle grafting can be performed. Here we see that here's a corneal conjunctival pedicle graft here. This one here that still has sutures there. Here in the United States, I use ADOT Vicryl to suture that conjunctival pedicle graft to the cornea, and those will dissolve on their own. This is a very large conjunctival pedicle graft that was sutured to the cornea. And this was from that photo previously that had the large hypopyon and the very large corneal, desmetocele. The pros of conjunctival pedicle grafting include that it utilizes the patient's own tissue. There's minimal inflammatory response. It adds strength to the cornea, and it adds active vascularization, which can help to clean up some of the corneal infiltrator infection. The cons of conjunctival pedicle grafting is that it adds a blind spot to the cornea. There's a large corneal scar, and magnification and surgical expertise are necessary to perform this graft appropriately. Corneal conjunctival transposition. Here's some various pictures of a corneal conjunctival transposition. And so this is the area of the conjunctiva that was slid in with the graft. Here is the normal cornea that was placed over the ulcer. And again, the sutures in the cornea. And this corneal edema will fade over time. Here's another CCT that was performed. This is the limbus that was transposed right here, as well as normal cornea throughout here, and then the conjunctiva right here. This is a healed CCT. It's a little bit larger scar than what typically forms, but this patient's still able to see. This was the limbus and then the conjunctiva. This one is also a healed CCT. This one was performed on a pug. I wouldn't recommend performing this procedure on a pug if you can help it, because pugs pigment no matter what surgical procedure that you do, but each one of these pigment areas through the cornea was done from the suture that was used to suture that in. And unfortunately, that's what pugs do. This is the limbus right here, and then the conjunctiva. This picture here is from this photo here. This is a small corneal scar throughout here, the limbus, and then the conjunctiva. And then this is another healed photo where there's a little bit more of a pigmented conjunctiva here. This right here is a hair, and then faint corneal scarring centrally there. But the benefit of this is to obtain more of a clear visual axis in these patients so that they can maintain vision. The pros are that it utilizes the patient's own tissue. There's minimal inflammatory response, although it's larger than a conjunctival pedicle graft. It adds strength to the cornea. It adds active vascularization. There's a clear visual axis postoperatively. The cons is that it does add a bit of a blind spot. There's a large corneal scar, although not as large as a conjunctival graft. Magnification and surgical expertise are necessary, which is more so than a conjunctival pedicle graft. So it takes a little bit more surgical skill in order to perform a CCT. So here's a corneal conjunctival transposition. So this was done on a cat with a sequestrum, but I wanted to show you the surgical procedure. It's very common to use on corneal sequestrums. So first, we remove the area of interest. So in this particular case with a sequestrum, we remove this area of diseased tissue. In a dog with a desmetocele, we would remove the diseased area around the desmetocele to create our recipient bed. We're using a 64 beaver blade here. We're going to make divergent incisions about 50% of the way through the cornea. Here we're going to use Stevens tenotomy scissors to undermine the conjunctiva. And free that up. Now we're going to dissect the top portion, the clear axis portion of the CCT using our 64 beaver blade. We're going to do our best to only minimally re-grab the cornea when necessary, and we're going to dissect that about 50% thickness back to the limbus. And here we're going to free our limbus. Using Stevens tenotomy scissors here, as well as Vannis scissors. So that's going to free our graft. So we can therefore have our graft there to place into our recipient bed. This is ADOT Vicryl. First, we're going to put 2 stay sutures at each corner in order to hold that in place. Then we come all the way back to the limbus. And we're going to suture this all the way around the graft, making sure we don't go full thickness into the anterior chamber in order to get that to sit nice and central. And as you can see here, you can still see the pupil right in the center, and that will help keep a clear visual axis for this patient. We're going to tie this off. And it takes about 4 to 6 weeks for that Vicryl to dissolve. So we switch gears here a little bit and look at Acell or Biosis grafting. And so this is an artificial material that is used, can be composed of mucosal subintestine or porcine bladder, pig bladder. And so we're going to suture that into the cornea. Here we see this about 2 weeks post-op, and the suture is still there. The graft is incorporating into the cornea. There's active vascularization and pigmentation. And then here we see the final product about 2 months later. There's a bit of a scar here from corneal pigmentation, but this patient is still able to see quite well. The pros is that there's minimal corneal scarring. It adds strength to the cornea. It's more comfortable post-operatively. The cons is that magnification and surgical expertise are necessary. It's easier to re-rupture these corneas because the graft is so thin, and these are extremely inflammatory post-operatively. So this was a study done by Chow and Westermeyer, which was respective evaluation of corneal reconstruction using Acell Vet alone in dogs and cats, about 82 cases. So a study done about 5 years ago in 2016. In this study, 82 eyes in this study were used where 68 eyes were having sufficient follow-up. There was minimal scarring in about 47 eyes, moderate scarring in 12, and severe scarring in 9. And there was a graft dehiscence in about 25% of eyes, or a little bit less than about 20% of eyes with 19 eyes. And I would say that that follows my experience as well. Corneal laceration are also emergencies as we see them in practice. They are frequently seen in dogs, especially dogs less than 2 to 3 years of age who met a cat for their first time. There's typically acute pain, and you may see iris protruding through the cornea. A laceration may involve the lens capsule, and this leads to cataract, lens-induced uveitis, and a potential for glaucoma. And phaco emulsification may be necessary in order to remove the lens if there is severe uveitis. So this is a case of a corneal laceration, and here we see that the cat claw went into the eye and was able to pull uvea into the incision of the laceration. You can see where the cat claw contacted the iris and is creating inflammation and fibrin within the anterior chamber. Here's a little bit more of a side view where we see the uveal tissue within the laceration there. That white area of the iris is where the cat claw struck the iris, and there's inflammation and fibrin. Surgical repair involved inflating the eye with viscoelastic, which is why we see this bubble here and this bubble here. When we see the suture, we push the iris back in with viscoelastic, so you can still see a little bit of where the iris was contacted with the cat claw. This is ADOT vicryl in a bootlace pattern. And then this is the laceration as it's healing. There's a little bit of fibrin right here in the anterior chamber, corneal vascularization as it's absorbing those sutures. There's post-op potential for intraocular bacterial contamination, persistent uveitis, glaucoma, and a retinal detachment. So our clients should be warned of these at all times. Post-operatively, we send these patients home with an e-collar for 2 weeks. Ofloxacin 4 times daily for 2 weeks, as ofloxacin achieves concentrations within the anterior chamber. Sometimes I do use topical nonsteroidals to help with the anterior chamber inflammation or uveitis. Atropine once a day for 1 week, oral carprofen for 2 weeks, oral tramadol for 2 weeks, and oral clavamox for 2 weeks. And we use oral clavamox because that gets into the anterior chamber quite readily, helps to clean up any bacteria that the cat claw may have introduced into the inside of the eye. So thank you very much. I appreciate you having me. It's always a pleasure to speak with everyone. I hope you enjoyed and I hope you learned something. I hope you have a nice day. Take care.